Thank you for joining the National Headache Foundation's Comorbidity and Migraine webinar. Today we're joined with Dr. Edmund Messina of the Michigan Headache Clinic in East Lansing, Michigan. Dr. Messina, thank you for joining us.
Thank you. And I guess I should begin, eh? In case of any Canadian viewers, you know, I said A. Okay, well, here goes. This is about comorbidity, and I'll explain what this all means in a moment here. Please don't be afraid. This is the Wolfman, Lon Chaney. I'm talking about the curse of migraine here, and we thought we'd bring in the old 1941 horror movie, because a lot of us feel, I mean, I too am a migraine sufferer, and you know, it's a bit of a curse. You know, you don't want these things. They're annoying, and they're more than just a headache problem, as you all know. Now, of course, as we all know, too, there's more than 38, some people say 36 million Americans. If you were to walk down the street and knock on doors, 1 out of 4 houses would have at least one migraine person living in it. And we're looking at 10% of school-age kids, and daily headaches, looking at 14 million people at least that we know of have daily attacks. So it's a pretty big deal. And the way we approach migraine these days is to look at the migraine disorder itself, but also to look at the comorbidities, which are the other conditions which go along with migraine, which interfere with making people better. Sometimes the only difference between a good treatment plan and a bad treatment plan is the attention to all the details that relate to the migraine, because if we don't fix everything that touches migraine, we don't get the migraine under control. Now, let me jump to this. Now, here's what I said I would explain is what comorbidity is. And it's any medical condition that exists simultaneously but independently with another condition. Or it's a condition that causes or is caused by another condition. In other words, when two things occur more commonly than the general population, we consider them comorbidities. And again, this sounds a little abstract, but I'll show you examples, and you'll see where I'm coming from on this thing. Now, in migraine, a lot of things happen more commonly in migraine people than they do in the general population. Like in migraine, certain people with migraine have increased vascular risk factors like high cholesterol, high blood pressure, and such people end up with vascular disease and stroke, which is very important because sometimes migraine symptoms imitate a stroke, but it's not a stroke. And sometimes the medicines we use for migraine are not safe in stroke patients, so this is a very important point. Now, from the psychiatric side, this is a really big one. In the migraine world, anxiety and depression occur more commonly than they do in the regular general population. And in the population of people in the psychiatry office that have depression and anxiety, they have a higher incidence of migraine than the general population does. So these are called bidirectional comorbidities. In other words, if you have one of these conditions, you have a greater chance of having the other. Now, the common chronic pain disorders also are more common in migraine people, like irritable bowel and fibromyalgia and osteoarthritis. And asthma is a very common thing in the migraine population. And this is important to us for a lot of reasons, especially that some of the medicines we use for migraine cannot be used in asthma patients, like beta blockers, especially propranolol, Inderol, can cause an asthma attack. So it's very important that the person treating the migraine patient is aware of this so they don't provoke problems. Now, epilepsy is a little bit more common in the migraine population, but not to a large degree. But the really big one is the sleep disorders. It's very common in the migraine population to have an increased amount of insomnia, either getting to sleep or staying asleep difficulties. And of course, this is a big problem because people that don't sleep well end up with more migraines. So now going to the American Migraine Prevention and Prevalence Study, this has been a very big database, big studies, and this actually reiterates what I just said, but about cardiovascular disease and cerebrovascular disease, you know, in other words, stroke and heart attacks. Now, the reason this is important, and again, your doctor needs to be aware of your medical history in great detail, because 18% of people with migraine actually can't use the triptan drugs. Triptans are the drugs like sumatriptan, rizatriptan, like, you know, Imitrex, Maxalt, Zomig, all of that. There are 7 drugs in that family. The triptan drugs are contraindicated in people with heart disease or stroke. People with leg pain that gets worse the further they walk. It's called claudication. It's due to arterial disease. Angina, chest pain, all these things cannot be used in patients with migraine. If someone has had a stroke or a heart attack, or might have a stroke or a heart attack because of their other symptoms, we can't use these triptan drugs, which normally are wonderful in migraine. So this is important. That's why, again, the treating physician for migraine must absolutely be careful and ask a detailed history. Now, meta-analyses, I'm going to just skip this. The bottom line is we worry about migraine with aura especially. Right, oops, I'm going backwards here. Migraine with aura, in other words, if you have a migraine with a warning ahead of time, be it visual or sensory, people who have an aura like paralysis or double vision, these are all aura-type associated symptoms. They are more likely to have stroke than other people are. Now, if you have migraine without an aura, just plain old migraine that doesn't have anything along with it, except maybe nausea, vomiting, light and sound sensitivity, if you have a regular migraine without the aura, the current data shows that you're not at a greater risk for stroke. So this is reassuring. Now, the frequency of migraine, the WHO, which is the World Health Organization, they find a higher incidence of migraine in people who have a higher incidence of ischemic stroke. In other words, when people have a blood clot, that gives them a stroke. Now, in young women, a big study was done showing only women who have visual aura, like I just said, over age 12, are the ones who have double the risk of stroke. So, again, this is 2 times the risk of a very small number, so don't get too nervous when you hear this. It's the risk of stroke is actually a small number anyway, so this is double the risk of a small number, but it means you need to be careful. Now, I'll skip this frequency and stroke thing again. Let me jump over to depression. A lot of work was done by Breslau, and showing how major depression increases the risk for migraine. And people who have badly controlled migraine actually have a higher incidence for depression. And it makes sense in many ways. Depression affects many functions in the brain. And if you're at risk for migraine and you're not having a very well-controlled depression, you're not being treated, you may have a higher incidence of those migraines. And certainly chronic pain increases the depressive symptoms in people who have depression. And in other kinds of headache, like cluster and other types of headache, this is not true. It's migraine that seems to associate with the depression. Now remember, there are about 200 different headache types in the classification system of the American or International Headache Society. 44 of those are migraine, and those are the people who seem to be connected with the depression. And it doesn't have to happen at the same time of your life either. If you're the person with the biology of depression and the biology of migraine, these may occur together or at different times in your life. Now, anxiety is another big one in migraine people, and it's more common in people who have post-traumatic stress disorder, PTSD. And we check for it in all of our new patients. We check for physical or sexual abuse histories and PTSD symptoms, and it's unfortunately very common in our population to find this. And these are people who have anxiety as well. Now, generalized anxiety disorder or panic disorder is more common in the migraine people. And this is important because when we treat migraine, there are ways we can prevent migraine that also benefit anxiety and depression. So this is why it's so important for us to understand whether a person has these 2 conditions. Of interest also is the OCD side of things. Now, again, I can say this because I'm a migraine person too. But those of us with migraine, most of us are control freaks. We have to control things around us. We're just not happy unless we're in control of a situation. We're attracted to careers like teaching and medicine and places where we can make a difference in some way in our view of the universe. And so the OCD side of it. Now, migraine people notice detail more than other people do. When you are using a medicine for epilepsy and also for migraine, like I don't know, Depakote or something. The seizure patients, they don't seem to notice half the side effects that migraine people notice on the same dose. We are like very detailed creatures, and that's why I bring this up. Now, getting help for anxiety, very important, is to look at the medicines that we use, because if we could find the ones that overlap with migraine control, even though they're off-label, in other words, they weren't made for this purpose, we sometimes can get some benefit. And these are some of the meds which are not, these are off-label meds for migraine, but they're considered labeled drugs and approved drugs for treating anxiety and depression. Now, notice I had mentioned the benzodiazepines, Valium, and Xanax. These will work for anxiety attacks, and some people even can knock a migraine down with one. But But these are very addictive medicines and have to be used with great care. You have to be very cautious. Now, counseling is a very, very good way to deal with anxiety. And again, people commonly will notice improvements in their migraines if they can get help for the anxiety, and that includes a combination of medicines and counseling. Now, a lot of people can benefit from, this. I'm going to move my screen around a little bit here. There, okay. A lot of people benefit from a technique called auto-relaxation or the relaxation response. A book was written about this by Dr. Benson at Harvard called the relaxation response. I sort of summarized it on this website. This is my MichiganHeadache.com website. If you just go to MichiganHeadache.com, you'll see on the screen there, you can click and get to this relaxation exercise. It's very simple. It's extremely simple. It's a way you can just learn how to breathe a certain way and tense and relax certain muscles a certain way. It puts you in sort of an altered state, which dissipates anxiety. It's quite effective. Now, mindfulness is another approach that's commonly used in the psychology world, and there are various self-help websites. If you Google mindfulness, you can find University of California and other resources, and I'll talk about that more here, maybe. Okay. There are various books and other approaches. It's a question of stress reduction. Now, we all have stress. We live in 21st century America, but some of us are more more the targets of stress than others. Some of us, stress will drive migraines pretty quickly. And if we can free ourselves from the stress and or at least minimize the effect of stress, these are resources here. Your local library would have, there's a particular book such as this. There are many things you can do for mindfulness. A lot of counselors will talk to you about mindfulness. There are some internet resources you can utilize, such as these. And if you can do a screen capture, or like an alt print screen on your keyboard, you can save these websites. These are all pretty useful. This is University of California, San Diego, and these are free, and these are the ways that you can help yourself manage stress. It doesn't take the place of a therapist, but it's one more step in getting help. Now, other internet resources are here. This is UCLA on this one. Something about California and stress. What does that tell us? We have some UK stuff as well. So these are all mindfulness resources, and if you want to just quickly, just know that they exist, and you can get them online. Now, sleep disorders is another one I wanted to talk about in detail. Is a very common problem in migraine people. Over half the people with migraine report difficulty in initiating or maintaining sleep, at least occasionally. And we're talking about how many days, maybe every day per week, maybe half the days of the week. It's very common. And our strategy in our clinic, and probably most other clinics, in treating headache disorders is to find ways to normalize the sleep-wake cycle. Because disrupted sleep can be, definitely can get in our way when we're trying to treat. And migraines can be triggered. About 50% of people will notice that poor sleep the night before can trigger a migraine the next day. By the same token, you can have a migraine in the middle of the night during sleep that will wake you up, and the intensity of the pain will sometimes crank out enough adrenaline that you will stay awake for a while. So these two go hand in hand. It's very important. Now, sleep complaints occur with greater frequency among the chronic headache people. People that have the occasional migraine once a month or something are probably less likely to have sleep problems than people who have frequent migraines, like more than 15 days a month. That makes it chronic. Now, an irony, migraine people have problems with sleep and wakefulness, like I said. The disorders of sleep and wakefulness can worsen a migraine. Now, headache awakening from sleep were reported by 71% of people. I mean, most of us have at some point or other been awakened in the middle of sleep by a migraine. And most of us will try to sleep off a migraine. But the irony is we can't always get to sleep if we're in that much pain. So sleep complaints, like I said, are greater frequency in the migraine world. Now, these can take many forms. Now, primary insomnia is one where you can't get to sleep. It's not because you drank a bunch of coffee, not because you were worried or anxious. You just plain can't get to sleep, or just plain can't stay asleep. You wake up at 3 o'clock in the morning, which some people call the witching hour, and no matter what you do, you can't get back to sleep. And the more you think about it, the more unsettled you are, and the more difficult it is to get to sleep. Now, sometimes migraine is associated with, or sometimes insomnia is associated with migraine or cluster. Now, cluster people will have classically, when they're letting down or relaxing, it's almost like an alarm clock, different from alarm clock headaches, but cluster can go off at a certain time every night in some people. Now, some people with migraine will have the same, with migraine will have the same experience. It's during a certain stage of sleep, maybe stage 4 sleep, that they get zonked awake. Now, sometimes we can get insomnia from taking the medicines, like people who take combination drugs containing caffeine. In modern times, there are over-the-counter drugs that contain caffeine and aspirin and Tylenol, like Excedrin. Prescription drugs, which aren't being used that much anymore, such as Furoset or Furanol, these contain caffeine. In the old days, before the triptans, we used Cafragot and Whitegrain, and those contained, caffeine as well. So the caffeine somehow makes the headache meds work better, but they also keep you awake. Now, some people are extremely sensitive to caffeine, and others can sleep it off, caffeine or not. Now, psychiatric illness, which, like I said, is common in migraine, can interfere with sleep also. People with mania, for example, or severe anxiety cannot get to sleep easily. Anxious people will develop what's called psychogenic insomnia, where they'll tell me, I just can't shut my brain off. I keep thinking about such and such that happened the day before, or something that's going to happen the following day. And these are common things. People with depression will either sleep too much or not be able to sleep at all. And some depressed people will have early morning awakenings, and they can't get back to sleep. So all these are possible things. And again, being aware of your other symptoms when you talk to your caregiver, that's important. Now, general health issues can also interfere with sleep. People who have obstructive apnea. Now, sleep apnea is more common than a lot of people realize. People with apnea, stop breathing at certain times, like up to 20 and sometimes 30 times an hour. And when you stop breathing, your oxygen level drops, and then your brain wakes up and says, take a breath. And people with apnea, either they sleep all night, but they don't have any restorative quality to the sleep. They don't wake up refreshed. Now, this is a big deal because hypersomnia or daytime sleepiness can be very dangerous. If you are falling asleep at the wheel, needless to say, it's a dangerous situation because you didn't get enough sleep at night. And now there's a type of apnea which does not involve snoring. Obstructive sleep apnea, commonly the people snore, their bedmates are elbowing them all the time, or they sleep in another room. These people, it's easier to suspect their apnea because they're so noisy. But some people have central apnea, and central apnea means that you're not taking the breath. You're asleep, but your brain is not saying take the next breath. And if these people are taking chronic painkillers like opioids, drugs that are like opium, like I don't know, oxycodone, hydrocodone, the Vicodin and all that, those things in high doses especially, some chronic pain clinics for God knows what reason give methadone and such. These can actually blunt your ability to take the next breath. And if you have apnea to begin with, and you take these medicines, your breathing goes even more slowly. And I've seen in the sleep lab really dramatic examples of this, in fact, scary examples. Now, the way we treat insomnia, this is important. And, buying a bunch of over-the-counter drugs is not such a great idea. Sometimes prescription medicines are helpful, but in the short run, better to use other strategies for the long haul. Some of the sleeping medicines are addictive, and some of them can impair your driving the next day. The FDA put a kibosh on the dosing for Ambien, which was the most commonly used sleeping medicine until about a year ago, when they decided that the safe dose is 50% of what people were using. And their argument was, well, you can take this drug and get to sleep at night, you can wake up alert the next day, but you're still impaired for driving. And you could almost get into trouble, you could possibly get into trouble if you were driving a car, got into an accident, and somehow they found out you were taking that medicine. You could be considered negligent. Now, sleep hygiene. That doesn't mean you have to gargle or wash your hair or something before you go to sleep. Sleep hygiene are the habits that a person has. It keeps them from sleeping properly. Bad sleep hygiene, for example, is taking evening naps. If you burn up some of the chemicals that you need to fall asleep later, evening nap people, like, the classic is the person is tired, comes home from work, eats supper, watches TV, falls asleep in front of the TV, and wakes up 11 or 12 or midnight or whatever, and then realizes, oh boy, I better go to bed. And then they go to bed and they can't sleep because they've used up the ability for the short term to fall asleep again. And poor sleep hygiene is being in a noisy environment. We're drinking a lot of caffeine within a few hours of bedtime. Really bad sleep hygiene is nighttime alcohol to fall asleep. People sometimes will self-medicate with a nightcap, it's called. And they get into sleep very rapidly, but they end up with using up all their deep sleep in the very beginning of the sleep cycle, and then they can't sleep anymore. And they're much worse off the next day. And, of course, the alcohol isn't so healthy for your liver and brain. Now, this is a good thing. You can find these things online. It's called Cognitive Behavioral Therapy for Insomnia, CBT-I. This is one of the new things in the sleep world that we are recommending to people now in our clinic and in others. The CBT-I it's done sometimes by specialized therapists. People in larger population areas in some of the sleep labs, they have psychologists or therapists who are specializing in this type of management of insomnia. They'll teach you about what you can do, and they'll get you to keep diaries of sleep and keep track of how much time you're spending in bed versus how much time you're spending asleep. And the online resources are these up here. I've got these from a recent discussion on one of the sleep webinars from the American Academy of Sleep Medicine, which I belong to. And these are, you have to pay for these things, but they're, and these are not commercial ventures, really. I mean, no one, either myself or the person who was giving this lecture I got this from, has any financial connection to these organizations. But these are helpful, and several of my patients have signed up for the 5-week one, and they've been to it now for a few weeks, and I think it's quite helpful. But it's a way to manage your sleep, and the better management technique, the less you're going to need sleeping medicines. So this is a resource again. Now let's go back to apnea. This is really important. When we meet people who have daily headaches, especially if they're a little bit overweight, and they're telling me how they fall asleep all the time, and they have to really be careful they don't fall asleep at the wheel, or that they at work, if things are boring, they're nodding off at meetings. I'm immediately really suspicious, especially if they have daily headaches. On a first visit, I'm always really suspicious they may have apnea. So I ask more questions about it. Now, like I said, the person with apnea will sleep many, many hours, but not have any restorative benefit from it. That they'll feel like they didn't sleep at all. They'll wake up, maybe 8-10 hours were in bed, but they feel like they need to get to sleep because they just don't feel refreshed. Now, apnea causes weight gain. And weight gain actually increases the number of apnea attacks because the fat builds up in the throat further blocks the airway when they go to sleep. People with blood pressure problems and diabetes or depression and anxiety are much harder to manage if they have untreated sleep apnea. And this is a real big clue in my world, with chronic headache, because most people I meet on a first visit are having very, very frequent headaches. And one of the first things I get suspicious of is their sleep-wake cycle, and of course, whether they have anxiety and depression, like I said. But really high on my list of suspicions is if I'm worried about whether they have apnea, we get a sleep study pretty quickly, because that makes my life a lot easier when I can get that out of the way, get them treated, so that we can worry about the migraines. And very commonly, the daily headaches tend to melt away when you get the apnea under control, assuming we got rid of the offending medication overuse and overuse of prescription or over-the-counter medicines. So again, we worry about the risk of stroke and heart disease, which I said is higher risk in migraine people, but especially migraine people with apnea, it's much more dangerous. Now, obstructive apnea is common in daily headache patients. People who have wake-up headaches, it's common with sleep apnea because they develop CO2 retention. Normally when you breathe, you're taking in oxygen and you're blowing off CO2 that your body produces. If you're not breathing enough times per minute, you accumulate CO2. And in the more severe cases, the CO2 retention actually increases blood flow to the brain, and not in a good way. So there's swelling of the brain to a degree that sometimes we could even see swelling when we look in their eyes and see their optic nerve showing swelling in the extreme cases. And these people commonly have morning headaches. Now, they may have migraine that's out of control, but they also have a different kind of headache in the mornings, like a dull headache, which goes away in about half an hour after they get up. And that's probably from the CO2, where they're normalizing their CO2 by breathing awake. Now, these people, like I said, is suspicious if you snore loudly, if you have non-restorative sleep, daytime sleepiness, and the classic, I can fall asleep anywhere. When you hear that, you got to be suspicious. Now, it's treated, again, in my world, in the headache world, I want my obstructive apnea patients treated, and CPAP is a continuous positive airway pressure. It's a mask that people wear. Some people, oral appliances, the dentists, certain dentists are trained in this, and you have to ask. But certain dentists can make a splint, not a bite splint, but a splint that you put in your mouth at night, and it pulls your jaw forward, and that opens up the airway. And it works just as well in most cases as CPAP does. And people with oral appliances don't hate them like the people who use CPAP. But a treatment of obstructive apnea, weight loss makes a huge difference. When someone gets to lose, and they start treating their apnea, they can lose weight. But when they lose, 20, 30 pounds, a lot of times their apnea gets better. They don't need to use the CPAP. So there's a lot of good reasons to find this disorder. Now, with migraine, is the migraine relating to the sleep apnea, or is it related to the insomnia? And it's hard to know, because sleep apnea people have bad sleep. You got to fix it. And throwing drugs at sleep apnea gets you nowhere. You have to treat the mechanical problem, and oxygen is important to the brain. Now, the F word, as we call it, is fibromyalgia, very common in the migraine population. In fact, in one series, that was published in Neurology a bunch of years ago, fibromyalgia was diagnosed in more than a third of the migraine population. And people with fibromyalgia, they have more insomnia. It's very common in these people, and a lot of times fibro people do better when you treat their sleep disorder. These people were older, they had headaches, they were more incapacitating than people without fibromyalgia. So again, when you have a lot of pain in your neck and on your other muscles, and you have a lot of chronic headaches, you got to talk to your people about this, because the treatment plan must incorporate all these other problems. Now, neck pain is common in the fibromyalgia crowd. Now, migraine people also have neck pain. Now, we have to separate the symptoms. The big question is, if you have intermittent headaches, if your neck pain only occurs on headache days, it's probably not a neck problem. It's probably the migraine referring pain to the neck. Because most migraine people will feel pain in the back of their head or in the upper muscles of the neck and trapezius, like a tightness or stiffness. Sometimes we'll feel it as the headache is coming on, and sometimes it's a warning. Sometimes it's during the headache, or sometimes it's in the period of time after the headache is starting to wind away. It's real common in the headache population to hear and see neck pain. Now, why do we consider all these conditions? Well, the whole issue here is when a comorbid state contraindicates the use of a headache medication, like I said earlier, heart disease and such, you can't use the triptans. And sometimes a treatment plan can make the other conditions worse, or sometimes the treatment plan for migraine can help insomnia, depression, anxiety, hypertension, because there are certain blood pressure medicines which also will prevent migraine. So that's why we have to know the whole picture. We can't just have a vending machine that's, put a quarter in here if you have migraines and out comes a solution. It's complicated, and it's not rocket science, but it's just you have to be thorough. So now, general somatic symptoms, these occur a lot in people with headache. Migraine people will have all these other symptoms. They feel like they have shortness of breath and palpitations and chest pain and menstrual cramping is more common in migraine people, female ones anyway, and joint pain, back pain, stomach pain. Migraine people are more sensitive to things than other people are, like I said earlier, so that's why these are noticed. These probably don't have anything to do with the actual migraine itself. So now, additional information, headaches.org, which is Headache Foundation, is National Headache Foundation, is a wonderful resource. There's a ton of information on their website. And on MichiganHeadache.com, I refer to a lot of the stuff that we talked about here. So that's what I had to say about the, let me just jump over here just to have something on the front screen here. Okay, so I'd like to answer questions if anyone has any questions. Usually these kinds of talks are best driven by the people in the audience who have specific questions. So let me open up to questions now.
All right, it looks like our first question, could low IgG levels as seen with common variable immune disorder affect frequency of migraines in people who also have chronic migraines? Are there any links between the two disorders?
Okay, see if I can, I'm not real clear exactly what you said. Something about with low IgG levels in people with immunological problems, will it be more like, oh, here it is. It's written on my screen. I'm sorry.
Mm-hmm.
Could low IgG levels, as seen with common variable immune system disorder, affect the frequency of migraines on people who also have chronic migraine? Are there any links between these two disorders? Not that I'm aware of. You know, the brain is protected by the blood-brain barrier. And if you remember back in the, I don't know, the 80s or 70s, whenever they had a big nightclub in New York called Studio 54, and they had bouncers there who wouldn't let you in the nightclub unless you were really cool or good looking. Well, that's how the blood-brain barrier works too. These cells that won't let certain molecules into the brain. And those molecules, the IgG, you know, the immunoglobulins are such huge molecules, they don't make it across the blood-brain barrier. So when people say they have allergic headaches or this and that, they probably aren't. It's probably a biological trigger rather than the immune system. But I'm not aware of any immunological problems causing headaches. But I do know that when patients are being treated for rheumatoid arthritis with immunosuppressive drugs, especially the biologicals, they will describe a lot of headaches at the time of when they're getting those infusions. They'll have headaches that flare up for a couple of days sometimes. There's a particular rheumatologist I'm thinking of who will give their patients an anti-inflammatory before they do the infusions. And that seems to block their headaches. Don't know why that is, but probably because it's an anti-inflammatory. I think that's the best way I can answer that question.
Thank you. Our next question. How does one work with daily depression and daily severe headaches with migraines 5 to 10 days per month? As a Yale graduate, I'd rather not be on Social Security disability.
Well, okay, now it's a good thing you're not talking to a Harvard person here. That's all I can say. No, but I just lost the thing. Okay, I'm jumping ahead back to the questions again. I'm sorry. Just bear with me a second. I just clicked the wrong thing. Okay, how does one work with daily depression and daily severe headache, migraines, 5 to 10 days per month? And indeed, we certainly don't want to see our migraine people heading towards a disability track because life is more gratifying when you're not disabled. The first question is, daily depression needs to be addressed, and psychiatrists have to be addressing this if the neurologist or the primary doctor isn't able to get good results within the first couple of tries. Daily depression is an entity of its own, and it's harder to control depression if you're in a lot of pain. And if you have daily severe headaches, I mean, these are things that have to be addressed. And again, I think about sleep disturbances, like I mentioned earlier. I think about sleep apnea. Anything which doesn't seem to respond, you got to look broader at the other things that can affect it. Now, daily severe headaches. The question is, why are they there? Are these migraine? Are these severe tension type headache? Probably not if they're severe. And are they some type of chronic cluster? First, you need a diagnosis, presuming that these are migraine. And migraine, would be headaches that that would produce light and/or sound sensitivity, nausea, worsening with exertion. Just in broad generality, those are migraines. If a person has chronic migraine, the treatment plan varies with individuals. There are many ways to do it. There is a whole host of antidepressant, anti-epilepsy, anti-inflammatory medicines that can be used. Some people respond very well with chronic migraine to Anabat, which is a botulinum toxin injections. It's unusual to see someone who doesn't respond to something, although I know they're out there. The World Health Organization says about 5% of the world has a daily headache to some degree. Now, if you're combining daily depression and severe headaches, it's hard to work. Of course, the depression affects your concentration, and so does severe pain, and it's hard to work. And a specialty person who can address each of these two problems, they need to be addressed. And if there's no obvious solution and the two are so closely linked, I would look very carefully at sleep disturbances such as apnea, because that might explain sometimes these two problems. It's definitely worth a search because very few people don't respond, although I know that it happens. So that's pretty much what I wanted to say on that one.
Thank you. Our next question, is there a link between undifferentiated connective tissue disease and chronic daily migraine?
I would bet there is, because it seems like so many people that we see in our migraine clinic, not so many, but it's common for us to see people who have this problem. And again, if we think about it, it's probably one of those comorbidities, like people with fibromyalgia and connective tissue disease. A lot of the arthritis conditions, they seem to be more common in the migraine population. Like I was saying, these comorbidities exist. So I have to say there's a link, at least in the occurrence of these two conditions. Whether they have the same cause or not is another question. If you think about the inflammatory changes which can occur with certain types of connective tissue disease and the mechanism of chronic headache, they both have inflammation in common. When a person has a migraine, there is inflammation taking place in the deep brainstem. The area is called the nucleus caudalis. A lot of times we will treat an acute flare-up of migraine, or when someone is in status migrainosus, which is a constant migraine, we will sometimes treat it with a short burst of prednisone, which is a steroid, which is an anti-inflammatory. So in that sense, these two have something in common. The treatment for one doesn't necessarily serve as the treatment for the other, unfortunately, but they do occur commonly.
Our next question. I had migraine, chronic pain, and now it's trigeminal neuralgia and occipital neuralgia. Is there a treatment you are aware of? I've been in pain for more than 3.5 years, and I'm in pain almost 10 hours a day.
Well, it's very, I would have to question how these diagnoses came about. Chronic pain, of course, is a general term. It could be anything, and migraine can be a type of chronic pain. But then to describe trigeminal neuralgia and occipital neuralgia, to have all of those occur, all three in the same person, the odds are so slim that they have something in common. The question is whether these are truly the diagnoses. Trigeminal neuralgia is very specific to the trigeminal nerve. There are 3 branches of the trigeminal nerve. And one is from the corner of your eye up to the top of your forehead, and one is between the corner of your eye and the corner of your mouth, the middle face. And the third division is below the corner of the mouth and toward the chin. And the pain usually occurs in only one of those divisions, and only on, usually, just about always, only on one side of the face. Now, putting that with migraine, the migraine pain travels in the trigeminal distribution. The trigeminal nucleus in the brainstem is where migraine is happening. That's the battleground for migraine taking place. But it's very different from trigeminal neuralgia, because migraine is a central nervous system problem. Trigeminal neuralgia happens in the trigeminal nerve itself, on one of the branches of the nerve. It's where the pain travels. So it's very different from the migraine. Now, occipital neuralgia can be mistaken for or a migraine can be mistaken for occipital neuralgia. Occipital neuralgia occurs on just one side of the head. At the very back of your head, there's like a groove or like a ridge that goes across. And toward the middle of your head and then moving forward, there's an area where you might be able to feel the occipital artery pulse. And right next to that artery is the trigeminal nerve. And when a doctor examines you for trigeminal neuralgia, you palpate that area, and if you get it just right, it shoots a zinger of pain up the side of your head toward the front, like in the shape of a banana. And that's the trigeminal neuralgia. A lot of people are being told they have trigeminal or occipital neuralgia when they really don't, and they might just have referred pain. Again, if it's both sides, it's possible that trigeminal neuralgia, but it's provoked by palpating. And the treatment of trigeminal neuralgia is doing nerve blocks of the trigeminal nerve. Now, to make it more complicated, a lot of people with chronic headache will sometimes, the migraine pain or the cluster pain will get better by injecting the occipital nerves. We don't know why that's true, but it seems to work out. But it's just, like I say, I have to question what these diagnoses are, because the fact that they can occur in the same person like this, it makes you wonder whether this is a diffuse migraine that's being attributed to these other conditions. Migraine can produce pain in the upper and middle face, certainly, but it's usually bilateral. It can be one-sided, but it's very different from trigeminal neuralgia. Trigeminal neuralgia, usually there's a trigger point on the face, like the groove between your nose and the mouth, called the nasolabial fold. Usually if you touch a spot there, it'll zing the pain. The pain of trigeminal neuralgia is very different from migraine pain because it occurs in volleys, like shocks. And if you keep stimulating it, it goes away for a while. It's very hard to confuse the two conditions, or in this case, the 3 conditions. I would talk to someone about making sure that's really the diagnosis. That's pretty much what I have to say on that one.
Thank you. Almost all meds give me migraines, even those that prevent headache. Is this common with migraine people, and is there a name for this phenomenon?
Yes. Well, I don't have a name for that phenomenon per se, but I think this stupid window of mine. Okay. Some people, I mean, every drug in the PDR, if you look up side effects, you know, the PDR, you know, or the online, you know, good drug, bad drug, and those kinds of websites, they don't tell you what percentage of the time a symptom comes up from a medicine. So every drug pretty much in the PDR has headache listed as a side effect. But whether it happens in 1% of people or 1 out of a million or 1 out of a dozen, you can't tell from these listings. A lot of migraine people will get worsening pain. Now let me narrow this down to 2 different types of medicine. There's the preventative medicine and there are the rescue medicines, okay? Now on the rescue or abortive medicines, like sumatriptan, Imitrex, if you take the dose too late into a headache, you can actually worsen the headache. And patients tell me that all the time. You know, they'll have a really bad migraine. They'll be, you know, suffering with it for hours and decide to go to an emergency room somewhere to get some relief. And sometimes an unenlightened clinic will give a shot of Imitrex way deep into the headache, you know, after the headache's been going for hours. And they usually get a lot worse. I mean, it's called allodynia. And it actually magnifies the headache pain because it was given too late. Most other drugs used to abort a migraine, like the analgesics or opioids or other such agents, anti-inflammatories, they shouldn't give headaches. There's always someone who gets a headache from one of these medicines. But to say almost all meds give me migraines, you have to ask yourself, are these migraines you're having, is this the allodynia that's going along with the headache? And are we talking about the preventative medicines causing migraine? That's another question. And a lot of the preventatives will sometimes have the opposite effect. We'll hear this commonly. The migraine population, like I said, is very sensitive to things, and we notice things that other people wouldn't notice. I don't have a name for the phenomenon unless we're talking about the worsening of pain by using, you know, sumatriptan. That would be called allodynia, A-L-L-O-D-Y-N-I-A. But I think there's always going to be some medicine that's going to work in somebody's migraine. If the taking of the pill or the medicine and within you know, like an hour the headache is worse, the question is, was the headache escalating anyway despite the medicine, or was the headache causing was the medicine causing the worsening? But it's important to get a good list of every med you've ever tried. The pharmacy could usually provide that, and really look at each one and think about it. And when talking to your healthcare person about this, because some medicines they might not have had an effect because the dosing was too low, and it might have seemed like the headache was getting worse. It's like when you're driving on ice. This is Michigan, we have a lot of that. If you're driving on ice and you want to stop and you step on your brake, it almost feels like you're going faster when your wheels lock, when you actually may not be going faster, but you have the perception that it is because you expected to slow down and you're not. And I would really look carefully at all these medicines. You got to look at whether the doses are the proper doses, and whether, especially if it's an abortive, you know, like a triptan, is it being used too late into the life of the headache? Because if you take it too late, especially wake-up headaches, a lot of times they get started before you become aware of them, and then you wake up, the headache is pretty bad. And if you use especially a slow-acting triptan, like an oral agent, it actually might feel like it's making it worse because you didn't catch it at the beginning. The injectable or the nasal spray of the triptans gets in faster, and sometimes you can offset that problem. But I would say, really, you should make sure that you really go carefully through all the possible meds and then sit down with your doc and really discuss this, because you need a solution. There has to be a way to treat the headache, and you can't just say all meds give me headaches. There's got to be one that's going to help you.
Thank you. Our next question is, would you recommend surgical insertion of a neural stimulation device?
Okay, would you recommend surgical insertion of a neurostimulation device? These devices are in their infancy right now. The research is going on. There's an occipital nerve stimulator especially being thought about for cluster. These are not perfected. They're having trouble with wires breaking, and it's something that tunnels under the skin. And I personally, in my clinic, would not recommend it because we have so many other things that work. We don't feel that becomes necessary. But the stimulation, now the non-invasive surgical or the non-surgical stimulation devices, there are a couple of them that the FDA approved over the past year. And one is, I can't remember the name of it because I don't recommend it, but where people hold it at the back of their head and they push two buttons and it sends a jolt of electromagnetic energy, which works a little bit better than placebo, although frankly, with 1.5 trillion connections in my brain, I personally wouldn't want to zap it. That's just me. The other device is Cephaly, which is being marketed by a company in Belgium, and the FDA approved it for intermittent or non-chronic migraine. And it's basically a TENS unit. It's a stimulator that it's like a little tiara you put on your head, and it's supposed to stimulate the first division of the trigeminal nerve. And according to the manufacturer, it suppresses migraines. The published data that I'm aware of shows about a 38% response rate. And in the U.S., 30% is considered placebo. So I haven't had anybody really benefit from that one. It's available, again, in the U.S. now, but most people with really bad headache who feel desperate enough to buy a device are people who have daily headaches, and it's not indicated for the daily headaches. And people who have a headache once in a while are not going to be so motivated to stimulate their head every day after work, because that's what you're supposed to do. So that's basically what I know about this. I think the future is going to be interesting because there will be some legitimate methods, I hope, of stimulating away a migraine. We know we could stimulate in a migraine by staring at a strobe light or other such things. There's got to be the corollary of that to turn off a migraine. I've been thinking about that for decades. I don't have a good way, but I bet we have a system someday that does that. So that's unfortunately, that's all I really can say about that.
All right. Our next question, how many chronic migraine patients actually revert back to episodic migraine? I've had chronic migraine for over 2 years, and I cannot get it to remit with many preventatives and lifestyle modifications. It's very frustrating.
Oh.
I've read studies.
Okay, I'll read it out loud. I'm sorry, I interrupted you. How many chronic migraine patients actually revert back to episodic migraine? I've had chronic migraine for over 2 years and cannot get it to remit with many preventatives and lifestyle modifications. It's very frustrating. I've read studies that say 75% of chronic migraine patients do not remit. What is your experience? Oh, it's nowhere near that. The majority of, like I say, new patients coming to a headache clinic, at least such as mine, are pretty much chronic daily headache patients, chronic migraine. And the vast majority, I'm not saying we're geniuses. What we do in the headache clinic is not rocket science. It's just you have to have a method. And but I'd say the majority of people who come to us with chronic end up with episodic migraine. It's just you need a method. Because how do you get to be a chronic migraine person? You need to be someone who has migraine 15 or more days a month, more than 4 hours a day. And a lot of so-called chronic migraine people, when you really look into it, they have medication overuse headache, or they have a comorbid condition, like I was saying, sleep apnea, sleep disturbances, anxiety, depression. A lot of these people, when you treat the big picture, they tend to come into more episodic patterns. Just taking away the offending medicine, if they're taking a medication overuse, if they're using, like I say, Excedrin or something over the counter, or Furanol or Furacet, Imitrex, any of these drugs, if used to excess, will produce daily headaches. And a lot of these chronic daily patients will actually, do better once you take away the offending agent. Of course, these aren't technically chronic migraine people. But if you look at chronic migraine where it's not due to rebound, or medication overuse, those people, again, the majority of these people end up eventually getting the headaches into more workable, you just have to find the medicine that's going to work. I'm glad you said the word lifestyle modifications, because that's a critical part of the treatment plan. But I'd say, when you're not getting good results with just looking at the migraine, you got to broaden out a little bit, pull back the camera lens to a wider angle, and look at the comorbid states that need to be corrected. That's been our secret to controlling headaches. It's not even a secret, but unless you treat the bigger picture with patients, you can't really get really good results in everybody. And certainly we never get results in everybody, but I'd say the majority, like I say, of chronic people will end up getting to episodic. Again, like I say, the the treatment plans, besides medications, there's botulinum toxin, which makes a very big difference in chronic migraine. In our experience, I'd say that 3/4, maybe even 80% of our chronic migraine people do significantly better with Onabot injections. So these are not stretches. This is really the reality. This is what we've seen. We've been using Onabot for 3 years now. So our experience goes back that far. So we have some people that are in their 10th or 12th injection now. It's every 3 months. And some people who figure, I don't need it anymore, will sometimes, revert back after 3 to 6 months into a daily pattern. So we restart the medication, the injections. No, it's treatable. Never give up, by the way. Never give up, because there's always something that's going to work. But talk to your providing, I hate that word provider, talk to your medical person that you see about looking broader at the comorbidities of migraine, because that might be the deal breaker. And that's the main thing I wanted to say about that. Oh, wait, I have one more thing. You said studies that say most do not remit. I don't know what studies those would be. It's not been my experience. A lot of times published data, I must say, it doesn't reflect reality. Like with multiple sclerosis, the published data says that the MS medicines reduce the number of attacks by 33%. But in reality, in looking back to '92 when we first started treating MS with the modern meds, I'd say people almost completely suppress the disease. It's not just a reduction. But the data that's published is based upon mathematical models, which may not be accurate. I think we need to improve the mathematical models we use in clinical trials, because they don't take everything into account. So that 75% number, I don't know where it comes from, but it's not realistic, at least not in my experience. And that's what I wanted to say.
Okay, looks like this is our last question of the evening. I've been a migrainer for most of my life. I'm now 51, chronic for the last 15 years or so. The only time my migraines disappear are when I'm suffering from seasonal allergies, and at the time I have no migraines. Upon my allergies subsiding, my migraines return. Any thoughts on why this happens?
Okay. Now, jumping here, okay, I've been a migrainer for most of my life, chronic for the last 15 or so years. That's pretty bad. The only time my migraines disappear are when I am suffering from seasonal allergies. At that time, I have no migraine. Upon allergies subsiding, the migraines return. Well, the first question I have, of course, is what are you taking when you're getting these allergies? Are you taking something that might be suppressing the migraine? I can't think of an allergy med that would suppress migraine. I know a lot of people will have a worsening of migraine during allergy season because the barometer, spring and fall, the barometer goes up and down so drastically, especially in places like Chicago or Midwest, whatever. People will do worse in those seasons just because the up and down of the barometer produces seasonal or weather-triggered headaches. That's very interesting. What you have the opposite of what our experience has been with thousands of people. I don't know why that would be, unless there's something about what you're taking that seems to suppress migraine. And the question is there some antihistamine that a person is using during those seasons, which in most people doesn't prevent migraine? Could for some reason that be preventing the migraine? There is one antihistamine that comes to mind, which pretty much nobody uses for allergies anymore, but it's cyproheptadine. It used to be known as Periactin when it had a brand name. And cyproheptadine is an antihistamine, but the molecule of cyproheptadine imitates a lot of the chemicals that constitute the brain, the neurotransmitters in the brain. And Periactin, in fact, many of you may already have had Periactin to prevent migraine. And that's an antihistamine that it's not because it's an antihistamine, but it's because it imitates other parts of the brain. And people with Periactin will suppress migraines dramatically, especially kids. Trouble is, in grown-ups, they can gain 40 pounds from it, which is not a good selling point, But otherwise, no, I can't explain when you have this opposite reaction to what we see, unless you're having some unusual beneficial reaction to whatever you're taking for your allergies. There's a Montelukast which is used for allergies. It usually causes headaches, but you wonder whether because technically it's an anti-inflammatory. I wonder whether that, some reason you may be benefiting from it. Don't know, since I don't know what you're taking, so I can't really answer it beyond that.
Thank you. It looks like that was our last question of the evening. I'd like to thank everyone for joining us, and please stay tuned to headaches.org to see our upcoming webinars. And Dr. Messina, if you'd like to give a closing statement, we thank you so much for moderating this session.
Well, thank you very much. And my closing statement is really anyone who has headaches that are not responding easily, you got to look a little bit broader at these things I talked about tonight, about sleep and mood and all these things, because comorbidities can make the difference between succeeding and failing in treating migraine. That's how I wanted to leave it. If you want to see more about the relaxation exercise, you know, our website is michiganheadache.com. And I wish all of you the best of luck with your headaches, and hopefully you don't have any more.
Thank you. Have a great evening, everyone.